Okay, so we'll go ahead and we'll get started. So good evening. I am Dr. Kim Blenman. I am an assistant professor in the Department of Internal Medicine, Section of Medical Oncology at the Yale School of Medicine, and an assistant professor in the Department of Computer Science at the Yale School of Engineering and Applied Science. I'm a member of the Yale Cancer Center and an affiliate of the Smilow Hospital. It is with great pleasure to be here today to moderate Smilow Shares Perspectives on the USPSTF breast screening recommendation. I would like to introduce our panelists who are experts and leaders in the field. The first is Dr. Mehra Golshan, who's a professor of surgery, breast oncology. He's also the executive vice chair of surgery and the deputy chief medical officer for surgical services at the Smilow Cancer Hospital. I'd also like to introduce Dr. John Lewin, who is Associate Professor of Radiology and Biomedical Imaging, Division Chief of Breast Imaging. And then finally, Dr. Rachel Greenup, who is the Associate Professor of Surgery, Breast Oncology, and she's also the Section Chief of Breast Surgery. So just a little bit of housekeeping. This is a discussion. So for those of you in the audience, please type your questions in the Q&A or the chat. So as we get started, so let's think about this. So breast cancer is the second most common cause of cancer death for women in the US. And so on May 9th, 2023, this year, just a few months ago, the United States Preventive Services Task Force, or the USPSTF, posted a draft recommendation statement on screening for breast cancer. So the USPSTF now recommends that all women get screened for breast cancer every other year starting at age 40. So this has caused really a lot of debate amongst our professionals and our patients, which has led to a significant amount of misinformation. So we here at the Yale Cancer Center and the Smilow Cancer Hospital felt that it is important to have this discussion today to dispel the rumors and to educate our audience on the USPSTF recommendations. So I just also wanted to remind everyone that this Smilow Share is eligible for CME. So as we think about this a little bit more, so for decades, the recommendation for screening mammography was annually starting at age 50. Then at some point, the recommendations for some groups changed. So what happened? Was there new data? So John, Dr. Lewin, could you please give us some perspective on that?
Sure, absolutely. So, well, actually, for decades, the recommendation was screening annually starting at age 40. And it wasn't until the USPSTF weighed in with their first recommendation, I think in 2009, that things became confusing. So was there new data? No, we are still using the same data that we have been using all along, which is from a group of randomized controlled trials that were done back in the 60s and 70s, with one trial in the early 80s, the Canadian trial. So these trials all showed a benefit, a reduction in screening mortality for women ages 50 and above. But they didn't show a reduction in that 40 to 50 age range when it was analyzed separately. And so the question is that just because there weren't enough people in that group so you could show a benefit? So the way a randomized trial works with mammography, and the way these trials all worked, is women were randomized to either be invited to have a screening mammogram or not be invited. And those were the two groups. And then they followed these women for 10, 20 years to see whether there were more women who died of breast cancer in the group that was invited to have a screening mammogram or the group that wasn't. Now, keep in mind, they were invited in years 1 and 2 typically, and then they were just followed. So they could do whatever they wanted after that. Well, quite frankly, it was unknown whether there would be any benefit from screening mammography. This was a long, long time ago, and we didn't have the faith in screening that we have now. And the whole question was, will this work at all? And the trials were conducted in the United States, in the United Kingdom, and Sweden, and in Norway, and they did show a benefit. If with enough time, they showed that the women who had been offered a screening mammogram died of breast cancer less than the other group. Now, even if you didn't get the screening mammogram, you were still in that group. So that diluted the power. So even if you're somebody who were offered a screening mammogram, you didn't get it, or somebody else was not in the offered group and they went and got one on the side, they were still in their group. So the fact it showed an effect was actually a little bit remarkable because there was so much potential crossover. So every trial except for one, the last one, which was done in Canada, showed an effect. And that one had some definite enrollment problems that came to light. So what's happened since then in terms of randomized trials? Absolutely nothing. And what's happened since then in terms of the data that the USPSTF analyzed since then? Nothing. What's changed is the perspective. Just, is it enough to just show a benefit, just to show reduced deaths from having screening mammography? Do you have to also look at the costs? How much benefit do you need to justify the costs of mammography? So what really changed was just sort of the philosophy of it, that we need to consider more the harms of mammography as well as the benefits.
So to follow up with that, so how strong are the recommendations in regards to net benefits? So the USPSTF listed this as a grade B recommendation. What does this mean for those of our audience who probably have, no idea of exactly what this actually means?
So it's interesting. Grade B is actually pretty high in USPSTF recommendations, but mammography is tricky. The number of women who get breast cancer seems high because almost everybody knows somebody who's had breast cancer. The number of women who die of breast cancer is much lower. And so you have to screen a lot of women to save a life. And with screening mammography, what was found in those trials and what has been found in what I'll talk about in a minute, observational trials, is that breast cancer deaths are reduced by about 1/3. So you can have screening mammograms, unfortunately, and still you will die, potentially. But we will reduce them by 30% for women invited to screening. If you actually go and get your screening mammogram, which is what all people in the audience want to know, your chance of dying of breast cancer goes down by 40%. So it's not 100% the way it is with some diseases. For example, cervical cancer is a typical example. We did very well with cervical cancer and pap smears prior to having HPV vaccine. Haven't looked, but I would guess that would get a grade A recommendation. Colon cancer, which I'm not an expert, has a lead time that if you can find a polyp early on, you can take that out and prevent colon cancer. We don't have that ability, so it's not as strong as those. The other things it's not as strong as, for example, vaccines, which have been shown to save many, many lives. But a B rating is actually quite strong. There's a C rating, and most of what you do, when you go to the doctor, most of what you do would be rated as insufficient evidence. A lot of things that doctors have been doing for their patients for decades, when the USPSTF finally weighs in on them, they find they really have insufficient evidence. A classic one that has to do with this is a clinical breast exam by your primary care physician. That has been a mainstay for decades. It sort of began to fall out of favor in the last couple decades, and USPSTF and the American Cancer Society both agree that it really has no benefit whatsoever. And similar things have happened with other exams. For example, primary care doctors doing rectal exams. So it's actually a pretty good recommendation in terms of efficacy in terms of benefit to have a B rating. What the B rating doesn't take into account, the B rating itself does not take into account the harms, but it takes into account, it's a measure, well, it does take into account, it's a measure of the net benefit. So I misspoke a little. They look at the benefit and the harms and they weigh them together, and that's where they get that B rating. No one disagrees that we can reduce breast cancer mortality with mammography. Certainly no one agrees at 50 and above. And there's strong evidence, 40 to 50 in many countries through observational trials, which continue to show the same kind of things. But what's really disagreed on, what's really unknown, is the magnitude of the effect and the magnitude of the costs of mammography. We could call them costs or we can call them harms. They're really the exact same thing.
Fantastic. And so just one last question for you, Dr. Lewin. So why this year? So we've known this data for the early screening for age 40, but it's just this year that we've started to, think about putting it in practice. Why this year?
So the USPSTF meets every so many years. It must be 7 years because they met in 2009, 2016, and again now. So they meet every 7 years. And so they met again. And why did they change? Well, you have to understand it's not the same people. Every 7 years, it's a different group of people, and they look at data that is highly contradictory. If you read the USPSTF's evidence document, the document that justifies what they did, you would not be able to come up with the conclusion they reached. You would wonder, well, what are they going to make of this? Because they had several documents. One was by a group at Kaiser, a research group based at Kaiser. The other was by this group called CISNET, excuse me, which draws models for them. And the CISNET group did models back in 2016 as well, and that was the basis of their recommendation. Sorry, and the CISNET models, they have 7 models, and they all are different. And they have to take all those into account and come up with a recommendation. And what really happened this go round was this group of people really didn't believe in the last recommendations. There's been no new data in the last 7 years. It was just a difference in this group. The one thing they did take into account more this time was the increased incidence and mortality for African-American women. So that had some effect, and that's what they cite in the press releases as the difference, why they think we should screen earlier. But if you look at the evidence documents, that wasn't most of the reason, but at least they are finally looking at it. They know that these randomized controlled trials were mostly conducted in white women, and they're finally trying to look at the effects of other groups in our population.
Thank you. And so, Dr. Greenup, so the American Society of Breast Surgeons have imaging guidelines. So how do they relate to the USPSTF guidelines? What differs? What's the same?
Yeah, so thank you for that question. One of the unique aspects of the ASBS recommendations for breast cancer screening is that it was really the first organization to frankly address breast density to include patient-specific risk and to talk about supplemental imaging in women with greater density or greater risk through shared decision-making. And so they really recommend that women over age 25 should undergo formal risk assessment, that annual screening should start at age 40 unless women are higher risk. It gave us some guidance around when to stop screening mammography, saying that we should stop when life expectancy is less than 10 years. And it included the opportunity to address breast density, either through use of supplemental screening ultrasound or supplemental breast MRI. And we now have reports on every mammogram about breast density and consideration of screening imaging to guide clinicians and patients.
Fantastic. So from a surgical perspective, what does it mean for women with dense breast tissue?
So certainly if women, personally, there's a lot of controversy about use of breast MRI nationally. Yale is actually very well known for use of screening ultrasound. And certainly if a woman's diagnosed with breast cancer, breast MRI can be incredibly helpful. It unfortunately is a highly sensitive yet not specific test. So the evidence reports up to a 20% likelihood or risk of a false positive, meaning that biopsies are performed and they result in normal tissue, and that can certainly impact patient experience in terms of anxiety and needing additional interventions. There have been several randomized trials. There was one done in Brazil. There was a trial called the Monet study and another trial called the MIPA or MIPA study, and all three of them showed that there was no difference in overall survival when MRI was used for women with breast cancer, nor difference in increased risk locally of a recurrence, but that use of MRI routinely resulted in higher mastectomy rates without improvements in reoperation for women with attempted breast conservation. We've had recent data from the Alliance 11102 study looking at women who have multiple breast cancers in one breast, and that's the only study I know of in terms of a randomized trial that shows that MRI does matter, but that's a very unique population with 2 tumors in one breast where we want to be sure there's not disease and intervening tissue before we offer them multiple lumpectomies. And that did make a difference in that cohort. So I think most of our community nationally is endorsing MRI for women with multiple tumors. Personally, it's a discussion I have with our radiologists. They are subspecialty trained to help guide us and when they can clearly see the cancer and when they would benefit from additional imaging. And with use of 3-dimensional mammography and good ultrasound in the hands of a breast imager, MRI should be used selectively to reduce the risk of false positives.
Wow, fantastic. So I'd like to remind the audience, please put your questions in the chat or the QA as we are moving forward. And so for Dr. Golshan, let's put this into perspective. So in the US, what is the median age at the time of breast cancer diagnosis, and what % of all new breast cancer cases in the US are in women under 45 years of age?
So thanks for having us this evening. I would actually start off with maybe some global statistics. There's going to be about 2.4 million, at least 2.4 million women worldwide that'll get breast cancer. In the US, approaching almost 300,000 with invasive breast cancer, 55,000 with ductal carcinoma in situ. In the United States, the average age is about 62. Yet about 10% of women will develop breast cancer who are on the younger side. And young has many definitions, but in this case, under 45, about 9 to 10% of, they'll account for 9 to 10% of our cases.
Fantastic. And so Dr. Golshan as well. So what is, the rate of false positives on mammograms?
Well, we have Dr. Lewin here, but if you want me to try to answer that, I'm a simple surgeon. I like simple numbers. So from what I know is that in the like say in the 50 to 60 age range, it's about 10% per year. So at 10 years, there's about a 50% chance that a woman may have a false positive, which would lead to additional imaging and potential biopsy. And the good news is most of the time it ends up being benign, but I'll let Dr. Lewin chime in on that.
Yes, and so the reason I threw that question to you, Dr. Golshan, because I know that you have a passion for overtreatment, and I was going to go back and thank you so much for throwing it over to the fence again to Dr. Lewin, because I wanted to ask him that question as well. So please.
So Dr. Golshan gets an A because that's a very good answer. About 10% is still the callback rate. We don't consider them false positives, but they are something where you have a mammogram and you get called back for additional imaging. So in a sense it's positive, but this is screening. And so you're screening and about 10% of the women will have to come back and have an additional mammogram and ultrasound. And out of those, about 1 or 2% will have to have a biopsy, and about those, just under half of 1% will have breast cancer. So if you take 1,000 women, about 100 will be called back. It varies depending on age group, just as Dr. Golshan says, and that's because we do worse at everything with dense breast tissue. We do much better if the tissue is not dense. And because of just through the years, technology has changed and our levels have changed at how we read. For a long time, we were very much focused on reducing the callback rate, but now with 3D mammography, we've seen there's a lot of very subtle cancers out there that we now know to have subtle signs, and we call them and we find them. So actually, I think the callback rate has bumped up a little. It was around 8%, but now I think it's trending back toward 10%. So, and the masters of mammography back decades ago when this started had callback rates 3 or 4%. What's the right answer? You can't really say it, but the studies that were done actually show that having a higher callback rate probably is beneficial because you end up finding more cancers than if you have a lower callback rate, and it's enough more cancers that it makes sense to keep your callback rate actually fairly high. So 10% is a great number. And yeah, it's not that each woman has a 50% chance, but what happens is the same women get called back over and over again because they're the ones that have the tricky pattern. So there are women out there saying, I always get called back. And the nice thing now in Connecticut, especially with screening ultrasound, we have additional screening, but it also helps us to just keep track of all these little things in women who have difficult breast patterns. Those patterns go along with other things like cysts, like little benign tumors, and we have to sort through all those and try to find a cancer. Screening ultrasound and screening mammography don't find tons of cancers if you look at how many people are screened, but when it comes to saving lives, it cuts the number of breast cancers by about a third, 30 to 40%, depending on which trial you look at. So that's, we don't call them false positives, but we could. Your chance of getting called back after a mammogram is about 10% overall, but there are going to be women who never get called back because their breast tissue is easy to interpret, and there are women who get called back over and over again because they have harder to interpret breast tissue. Unfortunately, we're learning through studying these patterns of breast tissue and studying with AI that it's the women with the complicated breast patterns that are actually more at risk for cancer. And the women who have the least dense breast that we're great at, we will catch every cancer, they have a lower risk of cancer. And if you look at the two groups, that number is between 4 times and 6 times. So if you're somebody at high risk based on your dense pattern, you have about a 6 times risk of those at the lowest end of the scale, about a 2 times risk of average if you use AI to look at that pattern.
Fantastic, thank you. So related to that, so that goes into the debate over the overdiagnosis and overtreatment of cancer in the US. So could you go into anyone from the panel, because I know that, everyone has a different take on what it all means. And I think it's really important for us to hear what that take is. And so could each of you, talk a little bit about what the debate is around both the overdiagnosis and overtreatment of cancer in the US?
Yeah, go ahead, Rachel. Well, let me start really quickly with overdiagnosis because we're the diagnosis people, and
Right.
Overdiagnosis, we're accused of that, and it's true. Anytime you screen for a disease, there will be overdiagnosis. We know that mammography causes some amount of overdiagnosis. And so what is overdiagnosis? So I'll talk about overdiagnosis, and Mehra and Rachel are the experts on overtreatment, especially Mehra. And overdiagnosis means we have diagnosed a cancer that would not have killed anybody if we hadn't diagnosed it. And we know we do that. You have to with screening because not everybody's going to live for years and years. There will always be patients who die of something else before that cancer would have ever harmed them. And that gets worse if you're looking at older and older patients. If you diagnose breast cancer in a 90-year-old, there's certainly a reasonable chance that something else will cause her to die before that breast cancer would have. So we know that there's an upper limit as to when we should stop screening, but it's different for each person. There are 90-year-olds who are going to live another 10 years, and that breast cancer is much more likely to be significant, and there are 75-year-olds who are not. So you can group them and come up with numbers as when to stop screening for the whole population, but looking at an individual patient is very different between the patients. But so how much do we overdiagnose? I think a good number is 10%, but you can see papers that range all the way up to basically 100%, that half of what we diagnosed would never kill anybody. That requires a little manipulation of the data. And the reason it's impossible to know is because the overall incidence of breast cancer is increasing over the years. It's continually increasing. So here's how you would test overdiagnosis. You would look at a population before you do screening and see how many breast cancers there are in a year. then you screen them all, and then you count how many breast cancers per year after screening. And if the after screening number is bigger than the before screening number, those extra cancers would have never shown up clinically. This is a lot to take in if you haven't already thought about this. The problem with doing that is, number one, we never have a population where we just suddenly start screening everybody. Even countries that start a screening program, it's very gradual, so you lose that. But the other problem is that the baseline incidence of breast cancer keeps going up. So the fact that we have more cancers now than we used to is not entirely due to screening. It's partly due to screening and partly due to overall increased incidence. So I would estimate I would estimate that's about 10%, 1 in 10 cancers the patient would not have died of. That's in the typical range, 40 to 70 years of age. But if you said 20%, there's no way I could really argue with you. If you say 100%, meaning or half the cancers, then so 50%, then I think that's a stretch. I don't think it's anywhere near that. And decrease in treatment is going to be the key, because we don't know we can't tell when we diagnose cancer which one we should be diagnosing, which ones we shouldn't. Once we biopsy it, we have an idea, but when we're just looking at the mammogram, we don't know ahead of time which of these cancers is going to kill anyone. And we have seen what looks like typical non-invasive cancer, and a couple of years later, it's a bad invasive cancer. I think I will stop there. I'm sure I have something else to add, but that's it for now.
Fantastic. Rachel? Dr. Greenup?
Yeah, so I have a public health degree, and the US can talk about overdiagnosis, but compared to other peer countries across the globe, we are really good at overtreatment, in part because we don't diagnose disease or provide access to care early enough. I think the idea of overdiagnosing is important in that we don't want to scare patients. We don't want to diagnose women with cancers if we're not sure they're truly cancers. And we don't want to provide the same treatment for pre-invasive breast cancer as we do for invasive breast cancer. And I'll let Mehra speak to that because he's really an international expert in that space. We do want to make sure we don't miss a chance to catch cancers that would be life-threatening or life-impactful. And so the key to appropriate screening and appropriate treatment is diagnosing a cancer that, when compared to the patient's overall health, would make a difference. So this challenge of knowing when to stop screening and aging in our aging population is a real one. We routinely see very small, non-impactful cancers diagnosed in women who are dying of heart failure, for example, or increasingly women who are dying from other cancers. And once we know about it, our job as surgeons and the multidisciplinary team is to temper the conversation so we think about the competing pressures on their life expectancy. But it's hard for patients, their families, referring to providers to think about diagnosing a cancer and not treating it at all. And so that's where I think our most impactful research will be in the next decade, as we think about tailoring treatment from patient to patient instead of a one-size-fits-all approach.
And building on what Dr. Greenup and Dr. Lewin mentioned, there is and I see some questions coming in through the Q&A. There is a subset of breast cancers, one specifically called ductal carcinoma in situ, or a stage 0 breast cancer, where the cancer is still inside the ducts and hasn't figured out a way to burst through the ducts or become invasive. We know that the overall survival for DCIS, whether you do a mastectomy, you do lumpectomy and radiation, or a lumpectomy alone, is usually over 99%. So a woman is unlikely to die of the disease process. And there's a subset, usually lower intermediate grade, often on the smaller side, where potentially the patient doesn't need treatment. Now, I know that's a couple jumps ahead of where most people are, yet there are trials that have been run both in Europe, both in the UK and in mainland Europe, and one that's being run in the United States, looking at what's called either active surveillance, which in the US tends to be imaging twice a on consideration because most of these show an estrogen receptor with anti-estrogen therapy versus standard of care treatment. Our European colleagues were a little bit more liberal, if that's the right word, where they just went through active surveillance with yearly imaging, no anti-estrogen therapy, randomized against standard of care treatment. And I think we will be able to identify a subset of women who may not need a lot of therapy or any therapy at all. We may not be there yet, but there are really nicely designed trials, which we are a part of, and other institutions are as well, looking at a question like this.
Fantastic. And right before we go to the Q&A, I want to ask one more thing. So there's a perception that the overdiagnosis and overtreatment does not seem to be as big of a problem in other countries. Is this really true? And what's actually leading that?
I can only address, I can address some of the papers I see are typically international papers. They criticize mammography worldwide. The things you do to decrease overdiagnosis is to stop screening at an older age and to increase screening at a younger age. The interval of screening doesn't really affect overdiagnosis because those same cancers that you were going to diagnose at year 1 will still be there in year 2. Most other countries, I will say, we haven't touched on how often you should screen. It's a tough problem, and there's no study that's compared 1 year to 2 year. But most countries around the world screen every 2 years as far as their organized programs. The United States has no organized program. We just have recommendations. And for a long time, we recommended yearly screening, and we really ended up screening about once every 18 months. And now with the recommendations 1 to 2 years, I think I really don't know how much that's really changed because we were already in between that number. But the way you decrease overdiagnosis is to not screen older women. And the other way would be to not diagnose this ductal carcinoma in situ that Dr. Golshan mentioned. And that's why these trials where they follow the DCIS are going to be so important to us. If we can figure out which cancers we don't need to diagnose, we'll stop diagnosing them, because he's absolutely right. It's almost impossible to talk somebody out of treatment once you diagnose them. I've had elderly women, and if I recommend, I think we should not treat this, they will definitely get it treated. And then at the end, they just thank me for saving their lives, even though I was like, no, I didn't save your life. In fact, I told you not to treat it, but they treated it and they were sure I saved their life. And that's just human nature. So once we diagnose it, our hands are a little tied, but it's great. There's a lot of new things coming up with treating things less. The old is surgery, radiation, and chemo was giving everything we got. Now we're looking at patients that may not need radiation. We certainly have patients that don't need chemo. And we're going to get at some point to patients where we don't have to actually do surgery. But I'll certainly leave that to the surgeons to talk about all that. And just one more thing about MRI, since we brought that up earlier, that's where MRI may have a big impact, is trying to differentiate the patients who need a certain amount of treatment from those who don't. The treatment we give right now is geared toward not having MRI. It's geared toward everybody needs lumpectomy and radiation. But with MRI, we may be able to say, hey, these people don't need the radiation. And there are trials like that. So I think that, as well as high-risk screening, is actually the future of MRI. It's true that for staging patients the way we treat them now, it does not have a big effect.
Fantastic. Thank you.
Oh, sorry to interrupt, Kim.
Please.
I think I'll piggyback on that. There is in situ carcinoma that likely benefits from treatment, and Dr. Don Lannon, who recently retired from Yale, did some great work in this space that probably detection of grade 3 DCIS that's more likely to convert to invasive cancer, as well as advanced therapeutics, has likely contributed to improved survival in a screen detected population.
Thank you. So there's a question from the audience. So how would a 20 or 30-year-old know their breast density if they have not had a mammogram? And Dr. Greenup, you had an answer to this. So could you please share?
Yeah, so
so that everyone can get
those of us who care for these women, it's very normal for women in their 20s and 30s to have dense breast tissue, and the description of density that comes out in the mammogram reports is really categorizing women of screening age. So I would say, in a practical way, but I'll let Dr. Lewin chime in on this.
Mhm.
Women in their 20s and 30s should expect to have dense breast tissue, knowing that as we age, the breasts become fatty or replaced, and therefore screening mammography alone is a more effective tool without supplemental imaging.
So thank you. So Dr. Lewin, could you?
So yeah, I
any
certainly
additional
agree.
thoughts?
Yeah, so sorry to interrupt. The real issue is that at that age, it doesn't matter if you have dense breast tissue. And as Dr. Greenup says, you should expect to have dense breast tissue at that age. What matters is when you get to screening age, when your risk of breast cancer is going up and your use of mammography starts, that's when it matters what your density is. So women of that age do not need to worry about whether they have dense tissue, because there's nothing that they should do differently one way or the other. It's only once they start screening that they should look at doing supplemental screening with screening ultrasound as the primary difference between dense and not dense tissue. And as we learn more, it may affect how they screen after, going along in their 40s and 50s, how often they screen and how they screen. But in the 20s and 30s, it's not a time to screen because the risk of breast cancer is so low. It is a time to get to know what your normal breast appearance is and your normal breast texture. And if you find a lump, you go to your doctor.
Fantastic. The next question from the audience is that, are the guidelines suggesting that women with 10 years of life expectancy no longer should have annual mammograms? And if so, does this portend that insurance won't eventually pay for them? This goes to anyone.
I mean, yeah, it's hard to predict how long we're going to live, right? And so I think it's really important for referring providers, primary care physicians, patients and their families, knowing their risk, to weigh in on the benefit and frequency of screening mammography. I think there's some research going on at Yale and also Dana-Farber Brigham, where Dr. Golshan led the breast program for some time, looking at this issue, both in women who have been previously unaffected with breast cancer and also women who have been treated for a breast cancer, in terms of how much is too much imaging moving forward. So personally, in my practice, I continue generally annual imaging in my breast cancer survivors until they start really having other health issues that both makes it difficult for them to come or stand for or tolerate mammograms, and also makes it so that, God forbid, we found a recurrence, we wouldn't treat it. So for example, women who have, end stage kidney failure, women who have, end stage dementia. And these are really important conversations we have with patients and their families.
Fantastic. Any other comments?
I think there was a question on, maybe reimbursement or insurance. And I think this is where, public advocacy and things like that can really come into play. Earlier this year, there was a preliminary decision from the Center for Medicare and Medicaid Services to eliminate coding for a type of complex reconstruction that a significant minority of women choose. But it was through public advocacy and those in the academic and community realm that came out, and CMS reversed their planned decision that would have taken away a significant form of reconstruction options for women. And I think similarly, if anything goes down the route of potentially limiting imaging, there are recourses that the public and the academic and private community can do.
Yeah, Dr. Golshan is absolutely right. Advocacy is the key. So the law is written that as far as screening tests, whatever the USPSTF recommends, that what will be covered by Medicare. But there's another law that overrides that for mammography, and that's due to patient advocacy. So coverage, and obviously most women under 65 don't have Medicare, but Medicare is what the other insurers follow. And of course, the ACA has certain requirements. So right now, insurance coverage universally will pay for a mammogram every year starting at 40. And in fact, there are still insurance companies, they'll pay for one mammogram between 35 and 40, and then yearly at 40. So this is all due to advocacy. So women here are lucky in that sense that they get to decide how they want to weigh the evidence and whether they want to have screening yearly or every other year. It's also a burden that they have to decide. They don't have the government telling them, but they are free to make their choice. Insurance will cover a yearly mammogram for the rest of your life. So there is no upper age limit as far as insurance goes. And reference was made to the 10-year rule, and that comes from studies, but in studies you could tell who lived 10 years and who didn't. It's almost useless. Excuse me, it's almost useless for an actual doctor to say, oh, you're going to live 10 years. We have no idea how long people are going to live in most cases until it gets down to a year or two. So the 10-year rule is not really useful, which is why nobody puts that in the recommendations. They just put an age. And for USPSTF, that age is 74, but that does not affect insurance coverage for mammography.
And so related to that aging question, again, this is all related. The question was, my friend and I are in our 70s diagnosed with breast cancer. We're appalled that research discouraging women at our age from having mammograms. So all of us had stage 1 or 2, or even through the article indicates that our life expectancy is 79. We will plan to hopefully live to be within our 80s and 90s, knowing that the longevity stats showing us we should have many years ahead. So how would you ever know where this cancer would have led? So we in our 70s see this as age discrimination and as money saving. So again, this goes along with the same topic that we've talked about it. I just wanted to add that out to share that with the audience.
Yeah, and I think that some of the science describes age as functional versus chronological age. And so 75 in one patient looks very different than in another, as does 35 and 35. And so it's really clinicians making thoughtful decisions that are tailored to their patients.
Exactly. Yeah, I think that's exactly right. And a lot of the background data is decades old, when 75 was older than it is now. So that has to be taken into account. The modeling papers are newer, but they have to rely on older randomized data because that's what we have. So where did that 74 number come from? It came from studies that were done decades ago, and they probably do not apply anymore. So it's really it's a area where we just don't have enough knowledge. And women are fortunate that they get to decide, obviously in conjunction with their doctors, whether to continue to screen or not. We have 90-year-olds who screen. They are extremely healthy, and even if they aren't, they want to screen. They want to just take this off their plate, and it is really a pretty small cost because they are less likely to be called back and less likely to have false positives. They're our easiest patients to read. So the main cost is just the cost of screening itself.
And then 2 related questions. So what's the guidelines for family members with first-degree relatives for diagnosis with breast cancer? And should a family history of breast cancer warrant starting screening earlier? Anyone?
So I guess another screening question. So the guidelines so these are guidelines. USPSTF does not weigh in on this question. They say there's not enough evidence for them to say anything. But the American Cancer Society does. And they recommend that if you look at your total risk based on various factors, primarily family history, so first-degree relative, and if that computation comes out that your lifetime risk is 20% or higher, so that's about a little more than double the average person, that you consider screening with additional tests, primarily breast MRI. So it's a little tricky because we can't screen all those women with breast MRI, and also because the cost of breast MRI, which is typically not covered by insurance in that it comes out of your deductible. is not the same as screening mammography, which is paid for from first dollar. But the American Cancer Society says consider screening with MRI if you have a 20% lifetime risk or more. So how do you figure out what your lifetime risk is? Your doctor's office can help you. Your mammography center can help you. There are tools online as well. The most common tool used is a model called the IBIS, and I'm not sure if it's directly available to patients, but there are definitely tools online where you can calculate your lifetime risk based on family history. But a first-degree relative who had breast cancer before menopause, so mother, sister, or daughter, is going to be a risk factor that will put you over that 20% number almost always.
Fantastic, thank you. So are there differences in breast cancer incidence and mortality between different races and ethnicities? So we touched on that just very briefly, and there's been some recent articles that have touched on that and what the implications of the USPSTF will have to some of that. To anyone, could you speak to that?
Yeah, I can take this. We see a significantly higher risk of breast cancer mortality in Black women in the United States, and this is at least associated with, but not entirely attributed to, a higher rate of triple negative breast cancer, which is a high risk tumor biology. There was a recent opinion piece in the New England Journal of Medicine, which is our very reputable medical journal, really arguing that changing in screening guidelines is will not make a difference in the early diagnosis and treatment of triple negative breast cancer, and therefore may not impact disparities, although the U.S. Preventive Task Force cited that a reduction in disparities is part of what prompted their recommendation for earlier and more frequent screening. I think the big picture message is that we certainly do not want to discourage our historically marginalized patient populations, nor anyone from health behaviors that improve early detection of cancer. And in part because we know that use of screening mammography is a very good proxy for a long, healthy life, in part because these individuals undergoing screening are also doing things like getting vaccines, having their cholesterol and their blood pressure measured. And so none of us would discourage anyone from undergoing screening mammography, again, especially if they struggle to receive access to care. So I think the important piece is that we allow individuals, regardless of race, ethnicity, background, to make informed decisions about their health care to improve their health outcomes and health behaviors overall.
Thank you. So what about the incidence and mortality information for those individuals who are Hispanic, Latino backgrounds, American Indian or Alaskan Native, Asian, or Native Hawaiian and other Pacific Islanders? So what about that? What about the information on those populations?
So there's an annual report from the American Cancer Society called Breast Cancer Facts and Figures, and it's wonderful in that it provides very detailed information, not only on diagnosis related to race, ethnicity, but also kind of incidence, disease biology, and survival based on races and ethnicities in the United States. We worry about breast cancer in all patient populations, and so we would never want to send the message that women of one subgroup, their breast cancer is less worrisome than women in another.
Fantastic. So to the group, one more question from the audience. So the question was, I agree with the previous patient comment about screening. I was diagnosed with triple negative breast cancer at 45 despite 4 prior negative mammograms. If I'd been forced to wait 2 years, I'd be metastatic. It was frustrating to hear this from the patient perspective. So that was a good comment. Thank you so much.
Yeah, there's, we know that for fast growing cancers, you can save a life by screening every year. So and all the models that the USPSTF uses agrees with that. Everyone's in agreement. It's just when you're at that level where you're trying to decide for the whole country, you're weighing, just like the EPA weighs the risks and benefits of having clean water and clean air. We don't think about it, but that's what they do. They think, how many lives are we going to save by having clean air and how much is it going to cost? Same thing that this group has to do, which is to weigh the costs and the benefits. But for some women, there's no question that a yearly mammogram is beneficial.
Fantastic. So the use of the term women in the USPSTF draft recommendations includes cisgender women and other people assigned female at birth. It does not include non-cisgendered women and cisgendered men. Can any of you comment on the implications of that?
So the USPSTF really can only talk about populations for which they have a lot of data. And there's just not enough data on transgender women or transgender men. And so for them, it's like most of the medical care we get, it's a patient by patient individual choice. We know that compared to a cisgendered man, all of those groups have a higher risk of breast cancer. The highest group is cisgender women, but transgender women and transgender men are in between, and cisgender men are the lowest. And in general, we encourage transgender women to go ahead and to get mammograms. We know they're at lower risk than cisgender women, but we still think that they should get mammograms. We know they have a risk of breast cancer, and the cost of the mammogram in general is very low and it warrants it. But it's a personal choice. We know the benefit's not as high, and it's just one, like many things in medicine, we just don't have the data that really guide people. I think we all learned during COVID that there's much more we don't know than what we do know.
Great. So where do we go from here? I know, are there additions that any of you would make to the USPSTF recommendations? And I would like to hear from everyone. So Dr. Golshan, do you have any thoughts?
40 and yearly thereafter for the average risk woman, and looking at actuarial life expectancy, when is the end date? Certainly, having 10 years, but that's not a perfect science by any stretch of the imagination. And as long as the patient is otherwise healthy, I don't think it's wrong to continue screening for a period of time once they do get to the older age group. Obviously, there are those with family history, certain ethnic and racial backgrounds where I think we should be much more nuanced and tailored in terms of screening recommendations. And, there are lots of experts here, in our center and around the state and around the country that can help guide women and others in this decision making.
Thank you. Dr. Greenup?
Yeah, I agree with Dr. Golshan. I think I would only add that it should be a multidisciplinary discussion for women who are higher risk, and use of supplemental imaging can be very valuable, but also should not be used ubiquitously in average risk populations.
Fantastic. Dr. Lewin?
So I would agree, but I think that women would like to know, should they get a screening ultrasound? Not just women, their doctors would like to know, should women get a screening ultrasound? Should they have screening MRI? What's the risk level where it will save lives? With those modalities, unlike mammography, all we've been able to do is count the number of extra cancers we can diagnose. And from that, we can infer that we're saving lives. But unlike mammography, where we had randomized trials that proved we were saving lives, with those modalities, we can't have those because those trials are very difficult to perform. And in this day and age, women know what they want, and they're not really going to allow themselves to be randomized. And we are not patient enough anymore to have 20-year follow-up, which is what we really needed to prove without a doubt that mammography worked. So we're going to have to just rely on secondary measures. I think there are definite populations where breast MRI is going to save or does save lives. We know that we find very small cancers in women who are at high risk. We know we're saving some of those lives. Quantifying the number is going to be very difficult. And same with screening ultrasound. There are definite cancers that are very significant that are found earlier because of ultrasound. And we know that somebody's life has been saved. What we don't know is what that number really is.
Fantastic. This has been wonderful. So are there any other comments that the panelists would like to make before we wrap up?
I think I made my speech, so I'm leaving it to Dr. Golshan and Dr. Greenup to make theirs.
Thank you, Dr. Blenman, for getting us all together and this leading this thoughtful discussion, and really for the audience for some really great questions. I've been trying to answer some, and obviously we've tried to answer some in real time as well.
Fabulous. Okay, so we are at the top of the hour, so I would like to thank our panelists for educating us today about how we should think about the USPSTF recommendations. I would also like to give a special thanks to Eric Weiner, Renee Gaudet, and Terrence Corcoran for organizing this event. I would like to thank all of you in the audience for joining us, and apologies for those questions that were not answered, we were not able to answer today. So the Yale Cancer Center and the Smilow Cancer Hospital has an amazing breast cancer group. So please feel free to reach out to any of our many breast cancer members with any additional questions that you may be having. So have a great evening. So thank you so much.
Good night.
Good night. Thanks, Kim.
Good night.